I'm so honored to be in this circle with such beautiful souls this morning. Wow. My sacred name is Bald Eagle Woman Who Leads, and I'm Cree from the Saddle Lake Reservation, so I'm kind of a transplant in this area, but I'm being adopted into many of the families, so I feel right at home because I'm right next door to the reservation. So it's an honor to be here with you today. Before we start, I wanted to just call in our ancestors in your own way. Call upon your ancestors, each one of you. We'll just ask them to come and be with us today as we start this gathering, and just have them come and guide us in a good way. I want to share my smudge with you too.
Oh.
Hi, hi.
Hi, hi. Grandmother, thank you.
Auksina pelkesti mantu kaksi vatsian. Minä naskum nanoskami ogiskakno tauinan. Magnaunan. Minä maskoatsuan minä nisuan kohta. Magnau gekahjaun waku maganak wista valkoistami paitsit. Great Spirit, ancestors, grandfather, grandmother spirits, come before you with a humble heart to give you gratitude for this day, yet another gift of life. I ask your blessings upon us as we commence this meeting. I pray blessings for each one of us in this circle, for our loved ones, our families, and above all, for the children, our future generations to come. I want to pray for all the good work that's being done within our communities. And I want to pray for all those leaders within our communities to keep them healthy, to keep them strong. Hi, all my relations.
Thank you, Grandmother. Thank you so much for helping us to begin in a good way.
Thank you, Grandmother Spence. I really appreciate you having the time to join us, and we really appreciate the setting us off on a good start for our session. So on that note, I'd like to start the session and welcome everybody to the table. Welcome all the participants that have taken the time out to join us in having a conversation, and thank all of the facilitators and all of the participants in those who are speaking and responding, who will engage in the discussion that we will all get a chance to listen to and provide some comments and generate our thoughts from. This session is on virtual care. It's sponsored by the Alberta Network Environment for Indigenous Health Research, so that's the Alberta NEAR. In which we are specifically focused on Indigenous primary healthcare and policy research. This seminar is one of many initiatives within this network that we will be facilitating over the course of the next 5 years. We have 1 hour to share together. There's chances, and there will be more chances to explore this concept, this topic very soon. For this session, could you please do the following? Just turn off your cameras and microphones. If you're not kind of the active speaker, that'd be perfect so that we don't have crosstalk. Use the chat box to ask a question or provide comments. We'll be standing by, monitoring and taking a peek at those things and integrating as best as we can. There will be a survey at the end of all of this that will pop into the chat box that we would really love if you could download it and fill it out and send back to us, because it's really meaningful for us to understand the impacts and your experiences and how we can do a great job and how we can improve. And so if you kind of have to pop out or you want to look at this again in the future, this session is recorded and we'll upload this onto our website. So here we go. So I'll just jump into a few slides here before we really get going. So you'll have to hear me speak for a bit. My name is Lindsay Crowshoe. I'm a family doctor I'm also I'm from the Piikani Nation, one of the Blackfoot tribes, and I'm also the nominated principal investigator of this research initiative. I'm an academic at the University of Calgary, and primary healthcare research and understanding that context for and with Indigenous people has been a center of my work. And so we're so happy and lucky to have resources from the CIHR to explore this further. The NEAR network is, ours is one of many, one of 9 across Canada. So it's a recent initiative funded by the CIHR. Each site across Canada has a different focus, but we do all come together to form this intermeshing network that we look forward to working well with each other. For our network in primary healthcare and policy research, we have some key aims, and one is to promote a renewed and transformed system of primary healthcare to achieve a better outcome with Indigenous peoples. We're thinking about equity and a whole host of high-level and critical concepts. We also aim to advance research that links knowledge, policy, and practice. So up and down this sort of spectrum of things that happen within primary healthcare that generates great knowledge and evidence to inform systems, that really balances and understands how Indigenous ways of knowing facilitates great outcomes and is central to excellent care, and how then it drives equity. So that's the basic stuff of our network. And if you want to know more about the network, we have much more information on our website to be able to tap into. Today's topic is around virtual care. I have a few slides here just to set the stage. And when thinking about virtual care, it's really important to have some sort of a definition. And here's something that I pulled down just recently in the exploration of it. And as a family doc, I've been engaging in it myself, and it's been really interesting, and I'll share a bit of my story with you on that. But these guys came about sort of defining this using a consensus-based process, which is pretty much up the alley of the individuals that are working on this NEAR grant, this NEAR project. So a nominal group technique to define this, and they speak to any interaction between patients and or members of their circle of care. So that's pretty broad, occurring remotely using any form of communication or information technologies, with the aim of facilitating or maximizing the quality and effectiveness of patient care. I think this has been an emerging thing. This has been virtual care has been the result of a crisis mode. So think about that. We have been able to actualize it more fully than what we've done before, because prior to this pandemic, I did not. I just provided care face to face, meaning that so the patient had to jump through all the hoops to get to our clinic, and that was where we did our business. And so bricks and mortar and people and patients along the way. With the pandemic, we needed to minimize risk, right? So think about the numbers of public spaces along the way that can transmit risk for infection, and and think about all of the other structural barriers that my patients in downtown Calgary, Indigenous population of Calgary at the Elbow River Healing Lodge face in getting to this. So we saw that was needed to be from a safety perspective, but when we shifted gears, we saw our volumes go up. Patients were like, "Whoa, this is great." Over time, and you can see the arrow going back and forth over time, with the request to by patients as well as by the healthcare system to say, well, maybe we need some more face-to-face visits. We started to shift back and forth, to having some face-to-face visits, and right now I think we're settling into some sort of an equilibrium that we don't know for sure what that's going to look like. But nonetheless, virtual care is here to stay. I would say We have policy contexts in Alberta that have pushed it and allowed it to happen. There's a relaxation of the policies within our professional organization of physicians across Alberta to allow it. There's a policy context within the ministry to say, hey, let's fund it and let's have some billing codes. So those are all contexts that seem to be making this feasible. And then, so thinking about virtual primary care is, and that is that it offers some interesting opportunities for enhancing access where there has been huge barriers to access. And that's, I think that's a good thing. And just a few more here. So there's a bit of research that we're starting to see that this slide shows some ideas that there are barriers, and we have to talk about barriers today, and what those things that we can do to facilitate it from stopping this altogether. I think that we have to think through how this mode sort of aligns with cultural safety, cultural competency, quality in general, and what it means from a geographical sense, and what does it mean in terms of a therapeutic relationship, and what does it mean to facilitate when we do have a resource disparity of physicians, Indigenous and non-Indigenous, as well as primary healthcare providers. That is the real case of why there's a discrepancy of healthcare service to and with Indigenous peoples. So this is one model of care that I think will be helpful in seeing and finding some solutions within the challenges of our healthcare system, specifically in the realm of primary healthcare. More background. So there's a wide variety of modalities, and I think if we can think beyond the single interface that say you as a clinician could have with a patient virtually, but maybe virtual care is a model unto itself, in which it has many opportunities, in which that virtual care, which could be a phone call, right? Most of mine are phone calls, because my patients don't have the tech or the access to Wi-Fi to be able to engage in a video sort of web-based approach, although we set ourselves up to do so. So there's a whole host of modalities. And so far, there's been great experiences about this. The second point is Australian literature. It aligns with my own experiences and the conversations I've had with the docs in my clinic around that, that patients have really appreciated the ability to access and come together via this medium, and it saves a lot of time. Much of our stuff that we do can be done virtually, but there's many parts that cannot, and so sorting out how do we balance that is kind of like part of our systems approach. And I think the idea of setting something new up that is a new mode is a opportunity for partnership amongst communities, amongst provider systems and Indigenous community. So saying that, our plan today is to hear a presentation from an existing model of care called the Virtual Doctor of the Day in BC. We have two speakers to provide that presentation, Ms. Eyrin Tedesco and Dr. Terri Aldred. Next, we will hear some responses from two reflective listeners. Number one, Dr. Stephanie Montesanti, who is one of our very own investigators, principal investigators for this network, and grandmother Doreen Spence. So you'll hear some reflective listening and adding to a conversation today. And then I will offer a few questions and be scrolling the chat function to include other questions or comments as we have ability, and then we'll close today. So that's the plan. So I need to hand this right over quite quickly to our two speakers, Ms. Tedesco and Dr. Aldred. So Eyrin is a clinical project director of primary care development in eHealth with the First Nations Health Authority. And Terri Aldred is a family doctor who I had the pleasure of working with when she was a medical student, but now she's moved on up and she's the site director of Indigenous Family Medicine Program, Family Medicine of the Carrie-Sakani Family Services Primary Care Team. She's the medical director for the Prince George Boundary Clinic and the Indigenous lead for the RC Lower Cap C BC. So I will hand it over to you guys, and I will be your slide mover. So there you go.
Thank you so much, Dr. Crowshoe, for the introduction. So I'd just like to start, thank you for the warm introduction. So I'm a Deckath from Clasden. I'm a member of the Lasilia, the Frog Clan, and I'm calling in today from the Lheidli T'enneh traditional territory, otherwise known as Prince George. And I'm one of the FNHA Doctor of the Day docs, which started back in April. And recently I became the medical director for primary care for FNHA. And I'll hand it over to Eyrin.
Thank you, Terri. Thank you, Dr. Crowshoe. Good morning, everyone. My name is Eyrin Tedesco. I'm a registered nurse by trade. My current role is as the clinical project director for eHealth and primary care development for First Nations Health Authority. And I'm coming at you live from the traditional territory of the Snuneymuxw Nation on Vancouver Island. Thank you very much for having me. I believe Terri and I have decided at the last minute, I'll run very quickly through our slide deck. I have a tendency to speak quickly, so if I've missed anything or you've missed anything I've said, please let me know in the chat box and I'm happy to go over it. Next slide. So the background around this is really for our First Nations Virtual Doctor of the Day, but First Nations Health Authority has been working diligently in the last 7 years around telehealth expansion in our 203 First Nations communities across the province. Deploying equipment and working closely with community to build programs that meet their needs based on their identified gaps in access to care across the province. So Doctor of the Day really came out of the dual public health emergencies of both COVID and the BC overdose crisis that's been occurring and has been deeply affecting BC First Nations communities. Very early in the pandemic, so prior to everything shutting down in March, a good majority of our communities had actually closed their doors. And so people couldn't leave, people couldn't come in, healthcare centers were closed, and healthcare providers weren't even allowed to come in and provide care. And so in response, we decided to launch First Nations Virtual Doctor of the Day April 1st, starting March 21st when I came back from Maui prior to COVID really taking hold in the province. And then subsequently launched First Nations Virtual Substance Use and Psychiatry Service in August, because that took a bit more time. Next slide. So the two programs run similarly and yet a little bit differently. We wanted it to be an easy one-stop shop for all of our First Nation citizens and their family members across the province. And so each line has a dedicated 1-800 number. Doctor of the Day is staffed 7 days a week, inclusive of stat holidays, 8:30 to 4:30. I have a physician in each region because BC has 5 regional health authorities, and our provincial health authority attempts to mirror those in a similar way. And so we have a northern region, an interior region, Island, Vancouver Coastal, and Fraser Salish regions. So there's a physician in each of them working 7 days a week for immediate access to primary care. It is a patient-facing self-referral phone line. There is a team of 4 MOAs ready to take your call at any moment and book your appointment as applicable to your region. It can be accessed both by Zoom or by phone, and that is to recognize the limitations and constraints that exist in some of our communities with regards to connectivity. In communities where health centers are open and do have telehealth equipment, we have actually changed out and recoded all of our hardware on the ground to be able to accept and push out Zoom calls. So if patients are comfortable seeing a physician in that manner and want to do it virtually, but don't have a smartphone, don't have the technology at home, or just feel more comfortable being surrounded in a healthcare space, they are welcome to access Doctor of the Day that way. The Virtual Substance Use and Psychiatry Service, again, separate dedicated 1-800 number. Being a specialty service, we've limited it to 5 days a week for very specific reasons. with regards to being able to support patients over the weekends in communities where we know that services often are depleted during those times. The referral has to occur from a health and wellness provider, inclusive of a GP or an NP, but really is open to referral from any provider in community. So be it an ADAP worker, a health director, a community health rep, an RN, an LPN, a social worker, a mental health counselor, they can all reach into the line and refer on behalf of the patient. They would connect with the MOA team first, and then there's a team of what we call care coordinators, which is a mix of addictions nurses, registered psychiatric nurses, mental health counselors, who really work with the incoming community-based referee of the patient to determine which pathway would best suit the needs of the patient in that immediate moment, and or if there are services of a lower to moderate level that could be better accessed in community or within their regional footprint to keep people closer to home. Again, it is a Zoom or phone-based call line. Zoom is strongly preferred, but we have done a lot of phone consultation where Zoom wasn't possible. And the purpose of this is really to provide addictions medicine, treatment, and counseling in community versus relying on the wait times to get into the system for treatment beds, either in the non-FNHA treatment centers and or within the FNHA treatment centers. Next slide, please. Basically, the premise of First Nations Virtual Doctor of the Day was not only to improve access and timeliness, but really to reduce the barriers and access to care in a way that provided culturally safe care to the population. And so what we do know, and particularly in my work over the last 7 years, working directly with community, is that in many cases, people don't feel safe accessing the care that is available to them. And so they simply don't go. And so what we attempted to do in this program is to develop an environment that really blends practitioners who are keen, willing to learn, and come from a very culturally safe space, and really to develop a primary care model that is led and co-designed and delivered by the First Nations communities that we are responsible for. Next slide. The VSUPS program, as we call it, which is our substance use and psychiatry service. Again, it was based on what we were hearing back from community as far as need. And then in conjunction with the opioid crisis that has gripped this province for at least the last 5 years, to provide that access to addiction specialists and psychiatric care. And we know that mental health and primary care are probably the two top identified care services in this province that are not being accessed or considered inaccessible by our communities in a way that feels good, safe, meaningful, and relevant to them. So it does provide addictions medicine and psychiatry service where every client encounter is aligned with principles and practices of cultural safety and humility across both streams. I think Terri and I have worked really diligently to ensure through our vetting process that our providers are safe, they are engaged, they are willing to take opportunity to learn more about the various nations, the various cultural nuances, and to really steep themselves into a practice of trauma-informed care. I am very proud to say that of the roughly 50 physicians I have, I think 30 of them across the board are of Indigenous ancestry, either from the province of British Columbia and serving their own home regions, as is the case with Terri and several of her colleagues, and or from other areas in the province or other areas of Canada and having moved into BC recently. Next slide. Are we done after this? Yes, we are. And that's the end of the presentation. Thank you. We tried to keep it quick.
Great job, Eyrin. Thank you. So I started with the DoD program back in April, but I've been working with Carrie Sakani Family Services for the past 7 years almost. And with that program, we would provide outreach and then we would follow up with telehealth. And we've been doing that for quite a long time. My predecessor, Dr. John Palovich, who still serves the communities, has been at it for now 10 years. And so I was familiar with providing primary care through telemedicine in the context of longitudinal relationship-based care. And similarly to many communities across the province, many of the communities that I served also closed, restricting outreach for almost 5 months. And so the emphasis on virtual care definitely increased, as well as utilizing web-based programs, because before the telehealth was mostly over like a machine in the health center. And so it still was new, or a shift to moving to Zoom or DoxyMe or some of these other pathways that have been adopted. And so for me, like virtual medicine is, I heard the term, I think coined by Alan Ruderman, about virtually enhanced care, or virtually enabled care. And so essentially it's meant to walk alongside a spectrum of services and to build those longitudinal relationships with people as much as possible. Due to the dual pandemics, as Eyrin mentioned, we also wanted to improve access. And so certainly virtual services needs to be done in the right context. And part of the emphasis very early on was trying to get the right people into these, into the Doctor of the Day or the VSEPS program, to be able to provide really culturally safe, very engaged care. And some of the feedback we've received so far really emphasizes that. We had one email from our complaints and compliments line. It was a compliment, and I'll just read you one line from it. I have never felt that respected, supported, and understood from anyone in the medical industry in a very long time. She made our difficult situation so much easier. And so again, just that emphasis on people really feeling cared for. A lot of people have really valued the time that we can spend with them over the virtual services, as well as the extended access for the Doctor of the Day program. It is 7 days a week, and so we can see people on the weekend. And certainly with these calls, people share often, why they're choosing to use the services. And a lot of times it was because they're in lockdown, they don't have access, or it's limited access, or they don't feel safe accessing care. And so in a lot of ways, the virtual Doctor of the Day program has really adapted and tried to meet the needs of the province. And looking into the future, our hope is that eventually we can help pair these virtual services with on-the-ground longitudinal relationship-based care. When the pandemic gets better, hopefully, in the coming months. Thank you. Oh, and I guess I can just share, as a doctor in the program, I'm somewhat lucky in the sense that I have been doing telemedicine for quite a long time. And so I was pretty comfortable with it. The newness was, seeing patients that I didn't know or hadn't seen in community already. And I think the biggest value is being able to have time to connect with them, and to be able to meet people from across the province and be able to help them in their healing journey in whatever way I can. And also, being really diligent to ensure that, we try to minimize gaps by connecting with their local doctors if that's something that they consent to and find valuable. And if they do actually have a family doctor, and certainly a lot of people who call in do not. And so we try our best to close that gap, as well as when we need to connect with providers if there's something more urgent that needs to happen, like if we need to send somebody to the hospital or if they need to be admitted. And that's partly why it's a regional program, because for me, I work in northern BC, and so I kind of know the services and usual referral pathways to be able to ensure that we get the person the timely care that they need. All right, that's all for me. Thanks.
Thank you both. That was awesome. I really appreciated that you guys set this up and have been delivering it, and it's something that we're privileged to hear about. And I hope that we can stay in touch to like understand what it is that you're doing, how you shift and change, innovate. How do you measure this kind of stuff? So there's a whole host of conversations and questions that it would be nice for us to connect across the Alberta BC boundary, our border, knowing that Alberta under Amy Glasvik, Dr. Glasvik, has developed a similar Doctor of the Day program that is just launched last week, and it's we'll wait and see how that emerges, but it's I think an amazing model of care that those are good things that move us forward. At this stage, I'd like to invite the first of the two reflective listeners to provide their responses. So I've asked Stephanie, Dr. Montesanti, to respond first, followed by grandmother Doreen Spence. So I'll introduce Stephanie at the moment. Stephanie is one of our principal investigators. I've worked with her for a number of years. It's been a pleasure to be able to engage with her in this type of work. She brings an amazing knowledge, expertise, context, and humanity to the work that we do together. She's at the U of A now, which where I went to medical school as well. So that's a nice context. And the other context I want to share is she's a 2020 recipient of the top 40 under 40 for Edmonton. So I'd like to hand that over to you. And after you're done, I will hand it over to Doreen Spence and introduce her next. So I'll stop sharing my screen and over to you, Stephanie.
Great. Thank you so much, Lindsay, for the kind introduction and the opportunity to provide some reflections on policy. Before I share some of my thoughts, I just want to congratulate Terri. Really appreciate your comments, but wanted to congratulate the First Nation Health Authority for the amazing work that you've done to really implement virtual care during the pandemic. Lindsay mentioned that we'll be talking about barriers, but I want to begin by speaking to the strengths and the ways in which the First Nation Health Authority was able to optimize virtual care strategies in primary health care. And we know that the emergence of the pandemic and public health measures that were introduced to limit its transmission meant that most services, including mental health services or psychological services, as you noted, had to abruptly pivot to providing those services virtually with little to no opportunity to plan for this switch. So our team here have been really interested in exploring innovations around virtual care and have been working to conduct some literature reviews or rapid reviews in this area. So it's great to start off with an example of how your group in BC has been able to implement this. So some of the things that I have noted in your presentation that really speaks to the ways in which you're able to optimize virtual care strategies within your primary care setting is one, embedding the health system leadership in virtual care strategies, which is really important. So you spoke about the number of providers across primary care and social care sector in the community that really came together to support the implementation and delivery of virtual care services. And I see that as an important element to this, but also with respects to provincial support in the implementation of virtual care. You highlighted the importance of patient-centered care, so focusing in on the patient. So we know that in any innovation or service that we deliver, the patient needs to be at the center. We need to understand the ways in which they're interacting with virtual care, how they're using virtual care, and the barriers and challenges that they might be faced with in accessing services and connecting with their healthcare provider in a virtual setting. So I think there's an opportunity going forward for ongoing evaluation, policy and practice evaluation, to better understand patients' experience in accessing services in virtual settings going forward. The other key element that you touched on was really bringing virtual care into the workflows. So we know that virtual care has resulted in a number of organizational changes. Many organizations have been quick to adopt new organizational policies, procedures, and practices to implement virtual care. Some of that requires involved educating providers and staff and feeling comfortable to use virtual care platforms to connect with their patients. But it's also changing the scope of practice as well. And so I think that's an important conversation to have, is where are the opportunities when we're talking about changing scopes of practice to enable virtual care services, and where the challenges might be, so that we can address some of those challenges as well. Flexibility, really key. So offering services 24/7, as you mentioned, Terri, I think was really important. So providing those services around the clock in order to meet the needs of patients when they need them. And I think that speaks to the point that you mentioned about why patients that you worked with appreciated virtual care and having that flexibility. And the time that you're able to spend in virtual care settings. And implementing platforms for communication between providers, patients, and families, as well as specialty physicians too. So connecting with specialty physicians outside of the clinic. And so I think that ongoing communication, knowledge exchange, and dialogue around best practices is really important. And that's how we learn, how we grow, and how we can continue to innovate and adopt virtual care in the primary care setting. So I wanted just to commend the work that you're doing and since supporting that, because that was another key point that I highlighted in your presentation. Next slide, Christiana. Now, there are what I see some implications with respects to how we go forward within a policy lens. So how do we actually plan for this going forward? As Lindsay mentioned, virtual care is here to stay. So building on my earlier points around optimizing virtual care, well, what might be some implications for future policy planning going forward? Existing organizational institutional policies can be a possible barrier. So there's, as I mentioned, many primary care organizations were quick to adopt their policies and procedures. But in some of the work that I've been doing around incorporating trauma-focused virtual care to serve diverse patient populations here in Alberta, I learned of a number of what these organizational institutional policies or barriers that can exist that we need to pay close attention to. So thinking about privacy laws, for instance, our Health Information Act, and how those might need to be adapted to ensure that we're protecting confidentiality and privacy of our patients. Is really important. Some service providers have noted that challenges with policies and procedures include responsibilities to know about licensing requirements around various or different virtual care platforms. And so while these might be implications, or in other words, barriers, I think it also offers us an opportunity to think through these in a more meaningful way. The other key consideration here for future policy planning is around patient safety and quality of care, virtual care. So I put there as an example, again, managing patient confidentiality and privacy in virtual settings. What I've learned is through some anecdotal evidence from primary care providers here in Alberta are concerns about being able to maintain safety in a virtual setting. And so when working with clients around mental health or providing psychological counseling or treatment as an example, how can providers attend to the client's space or their environment to know that they are in a space or they are connecting virtually in an environment that is safe for them to do so, that they're not at risk or at risk of further harm by sharing some of their concerns, feelings or stress around how they're feeling with their healthcare provider. Relationality. So Lindsay talked about, and so did you, Terri, around the therapeutic relationship. There are some concerns that we've been hearing, and it's not just in the evidence or literature, but even through some of the research that I've been doing here in Alberta, is the loss of that human connection in virtual care. This wasn't something that you had noted as a challenge, and you actually had spoke to the fact that it provided an opportunity to enhance that relationship, but relationship-based care is something it requires ongoing work and meaningful consideration going forward as well. So thinking a little bit about that provider-patient relationship and how that can be maintained and protected and supported within the context of virtual care. Incentivization and funding. This can refer to billing codes, as Lindsay mentioned, but I think one of the things that we've noted too is that the funding structure, not just in Alberta, but across the country, rewards organizations and primary care providers for activity instead of outcome. And this has always been an ongoing concern, not only in the context of virtual care, but in many different areas. And so, but it still very much holds true in this context as well. So how do we actually evaluate the outcomes around virtual care to ensure that we are continuing to address those patient health outcomes or metrics that our organizations support and that are meaningful to us and also meaningful to patients' needs and experiences. The other key consideration going forward for future policy planning is addressing the digital divide. And where there's strong evidence base for how to implement virtual care has been in rural and remote contexts. And there is a growing literature and evidence base to support this before the pandemic. So that's really been a starting point for us where we can identify some important policy lessons that can be brought forward and considered within our current pandemic context. But the digital divide still exists. And what we're learning is that many organizations and providers are finding that that's being built into their scope of practice or within their workflow is supporting their patients to connect virtually and use virtual care platforms. Next slide, Christiana. Or actually, yeah, my last slide. So I wanted to end by speaking to some of the opportunities for enabling a more informed policy development on virtual care. So I'll just highlight 3 key implementation considerations. You spoke about this, Terri, with respects to intersectorial collaboration as being really important. So connecting with primary and social care providers around this, so in sharing best practices, lessons learned, as well as supporting providers to enable them to continue to provide their services virtually. And lastly, again, bringing back the focus on patients. We can't do this without knowing what the experience has been for patients and building that into how we continue to design and implement virtual care. So I'll stop right there.
Thanks, Stephanie. And you had a small window before the rambunctiousness started. Hey,
I know. Sorry about that.
it's completely great. It's good to add that to our mix. So thank you very much. I'm working through the thoughts, and I feel likely everybody is thinking about what's been said so far. I'd like to I'd like to introduce grandmother Doreen Spence now. I'll just share this this slide again. And it's my pleasure and honor to introduce grandmother Doreen Spence, originally from Saddle Lake. She now lives in Calgary. She is a traditional healer, a retired registered nurse, a Nobel Peace Prize nominee, author, and human rights activist who served as a presiding elder on the working group for the UN's Declaration on the Rights of Indigenous Peoples. She's 83. She's an active lodge keeper, and she is a huge supporter to many people in our community. So I'll just stop sharing my screen and hand it over to grandmother.
Well, welcome. I just wanted to say thank you to the speakers and to Dr. Montesanti. I thank you for your summary. I want to take a different approach from a traditional perspective as an elder. My first job when I first graduated, I was seconded to a small hospital up north, the High Prairie Hospital. And so for me, it was a hands-on experience to be in a place like that. And I spent over 4 decades working in active treatment hospitals. So I come from a very long line of, I guess, hands-on experience with not only the traditional communities living in and being brought up by my grandparents who, both my grannies were healers. So looking at all the information that we received this morning, one of the first things that I thought of as an 83-year-old granny, which really struck me profoundly, this is the way of the future, and we have to adapt to the means that we have, and we have to be able to move forward with these computers and so forth. I myself, I'm at a disadvantage because I'm technologically inept. I have basic skills. I'm self-taught. I do not have a cell phone. And I'm sure that I speak for many of our elders within our community because I know I'm with them quite often. So that is a disability, I guess, that we do, or disadvantage that we do have. The other thing that concerned me was the cultural knowledge. It's so imperative to have the availability of elders and I'm not quite sure how that fits into the current programs that we have running virtually. Because for me, smudging is absolutely critical. That's how I start my day. That's how I receive the strength and the balance to get me going and to help me throughout the day. It's important to have the spiritual assistance too. So having elders within the community or availability to elders is critical. The other disabilities I noticed for me are sight. You know, I cannot see some of the fine prints on the computer sometimes, or certain visual things I cannot really see. So that's a disadvantage. Hearing is also something that I have struggles with, and so making sure that our computer systems have all of those technologically available to us. one of the things that really stood out for me was the 24/7 care that's available, because I live alone and I don't really have a family physician. So having somebody available like that, knowing my history and stuff, would be good. I am concerned though about privacy. I think I know that there are some online things available to me, but I'm afraid to give any of my personal information to just everybody. So I don't do online banking, and I don't do online access, or I don't access the availability of what is out there for me in terms of health. And the specialty care is important. Also, the 1-800 number, that really stood out for me, because if I can talk to somebody on a one-on-one like that, that's very important. Best practices is also critical. And we've been dealing a lot with systemic racism. And to me, it's important that the person or team that I access have the respect and the knowledge, more importantly, of Indigenous culture. And there are instances that we've had where that systemic racism is not going to go away right away. And so that's very important to address some of those issues. So those are some of the things that stood out for me. I was on the computer yesterday with Dr. Cindy Blackstock, and she was talking about how important it is to really address the issues of racism. So I wanted to just sort of put that in there too, because you know, we need cultural knowledge in the system is very important. So thank you.
Thank you, Grandmother. Those are really important thoughts, and thanks for contributing and sharing and adding to the conversation. So as I mentioned to in the development, I was asking for each of you to think about what was said and add something to the table, so that we have lots to chew on and lots to think about and lots to continue having conversation. One second, I'm just going to reshare my presentation. Hopefully it's going to work. I think so. So we have a little bit of time left, and I'm wondering if the two presenters and our two reflective listeners can keep their videos on and mics on. And I framed a few questions, and I'll keep my eye open for other questions that have emerged. So keep this in mind. These are like 2 o'clock in the morning questions, so they start to like look good to me, but maybe they aren't that good. For me, that's super okay if we want to just chat about something else. But these are some ideas that I was wondering about and saying, oh, I'd like to hear more about this and hear your thoughts as a group of people. The first question that I framed last night was around digital health literacy, not just for patients, but for providers. And as we're speaking for systems, right? for policymakers, there's a whole literacy that has to be built. Literacy is a critical enabler of virtual care modes. And what are key strategies for building that capacity was one question that I had. It's not bad. I think we actually touched on it a bit, so I'm happy. My next question, and we don't have to explore all of these. I just was wondering your thoughts. If you want to tackle, start to jump into one, that would be great. Episodic use of virtual care outside of an ongoing primary healthcare relationship risks continuity and perhaps undermines healthcare outcomes. what are considerations to address this risk? And I've heard you guys speak a little bit about that, so that's great. So I wasn't totally out to lunch at the time of thinking about these questions. Quality of care is linked to the nature of the therapeutic relationship. Considering possible limitations of virtual care, what approaches are key to facilitate a therapeutic relationship grounded in Indigenous ways and preferences for engagement? So I was pleased to hear a touch base on these concepts. My interest is if to hand it over to anybody of the four to respond to one of them, and let's just chat a bit before the session ends. And to note that we do have another session coming up in December that will allow us to spend a bit more time on this subject, as well as other subjects, topics within Indigenous primary healthcare in December. So I'll hand it over to you guys for any comments at this stage, or even if it's just closing ideas or something that you wanted to say but didn't quite say, or something that somebody else said that you wanted to. So there you go, Eyrin.
I just wanted to address a few points in Stephanie's presentation. One, to clarify to the group, we are not a 24/7 call line. We are 7 days a week, inclusive of holidays, but we do only run 8:30 to 4:30. With regards to fee structures, our physicians are actually salaried contract. So they're not a fee-for-service model, which does afford them time. And in having done this work and worked very closely with our Provincial Ministry of Health, there is discussions now starting around how we change certain billing codes for primary care with regards to First Nations care provision, recognizing that it is often more extensive and time consuming than your standard 7-minute in and out. So those policy level discussions are already starting to occur. I think around the digital health literacy piece for both patients and providers, I have to really reiterate, this wasn't new business for us. A lot of our communities have relied on virtual means over the last 10 years as their supportive mechanism to being able to have care reach into their home communities. So while it is sort of wider spread and appears very new for many of our stakeholders provincially, I would argue that virtual care for First Nations populations is not as new as it may be. It has very much been a mainstream model of care in a large majority of our communities across the province. And I always get antsy around the term virtual because it seems to just intrinsically imply that it must be a technological delivery method. And sometimes it is as simple as just picking up a telephone. So it's not always a Zoom or a DoxyMe or a Medio or whatever, Babylon, whatever's out there these days. It is sometimes just as simple as picking up a phone and having that conversation. So that's really all I want to say about that.
Thanks, Eyrin. Any other thoughts to put on the table at this point?
Just wanted to say thank you, Eyrin, for that clarification. And I think it provides some important insights around what those considerations are within our context here in Alberta and elsewhere too. But I appreciate you making that clarification. Thank you.
To speak to one of the questions in the chat box around health literacy and access to technology. And so certainly that having access to technology or Wi-Fi or a phone or a computer or something to access certainly has come up as a barrier. And as a barrier that we've known for a long time, again, as Eyrin said, a lot of our First Nations community has been in the virtual world for a long time, and getting that access and service to telehealth has been a challenge. And I think one of the things that COVID has done is really made that very apparent. And so now it's being recognized or as a social determinant of health and is something that policy people and the government is starting to see as important. And I think that will help to hopefully improve access to those things, as well as within like our urban and away from home program. I know that there was a donation of a larger number of devices to help kind of improve access for people in that population for different services. And so I think that there's some good work being done, and certainly Eyrin and the eHealth people within FNHA are working really hard to help close those gaps. I think it's one of those things that anything that's new can often come with some hesitancy, both from people providing the care, but also people accessing the care. And once people get used to it and get socialized to it, you know, it's another skill. And, you know, again, Dr. John Palovich, he started doing this work 10 years ago when there was a 3-second delay in TACLA landing. And it was still a service that was really, that really helped improve access, that helped connectivity for the nurses who were there 24/7, but also helped him connect back into his patients so he could do follow-up. And so, which kind of comes to the quality of care piece. You know, certainly, you know, virtual care is amongst a continuum. And as I think both Lindsay and Eyrin had referenced, you know, we've used technology to provide care for a long time, whether or not that's through our electronic medical record or calling a patient to tell them results, or, you know, some people have used, you know, texting platforms or emails to help clients book appointments, you know, things like that. So really a lot of our care is virtually enhanced. And like when I was in medical school, one of the things they taught us is that, you know, a good thorough history helps you to attain a lot of the information you need. And then your physical exam is really meant to tailor to the information gleaned from history. And, you know, one of the benefits of having access to things like Zoom or telehealth unit is that we can ascertain a lot of information by being able to see somebody, to get a bit of a, I always say, a gestalt or a sense of how that person is. And so there, you know, there is a lot of things that can be safely done over virtual means. And it's really important, again, building those skills so that when there is something that's out of the scope or that needs to be handed over, that we can do that in a good way as well.
Thanks, Terri. I really appreciate all the second level thoughts that we put that came to be in our time together. I'm super keen to explore this further and have some more chats. I think there's some nuance that we have to think about and talk about in terms of addressing funding and policy around funding and paying of physicians, and the push in Alberta to decrease each care visit, and what does that mean from a fee-for-service versus an alternative relationship remuneration program that seems to be key. I mean, that's how I'm paid, and it's fundamentally changes the way that I practice since it's been in existence, and it shifts us from what Stephanie speaks about was volume-based care or activity-based care to quality of care. And so I've had to argue many times when I was the director of the Elbow River Healing Lodge that increased volume doesn't translate to higher quality. It's actually lowering the quality. So there are many conversations that we have to have. So I need, considering time, it's time to close. And I'm going to pass to this slide really quickly because I think we chatted and started to explore these concepts that I put on this closing slide. But I wanted to highlight that that there's many areas that we probably should look more closely, right? We'd like to be able to do this in collaboration. to understand what are ways to evaluate, what are appropriate models that incorporate us as Indigenous peoples in all aspects of a model of care that integrates, say, technology, virtual, whatever we want to call it. And then what are the structural and systemic issues and the knowledge that is required to help to shift systems. So there's some complex things at play. And there's innovations in technology that I think we have to think about, knowing that how does information travel with patients, and how does this work from a model of care? So there's some things to think about. And across Canada and across the world, systems are talking about this, and I think it's time for us nationally, as Indigenous primary healthcare, to have a forum on this, like a formal exploration that explores the nuance. So just reading some of the literature, there's so much out there that needs to be done collaboratively, and I'd like to be able to position us to be able to help that. So we will start to do that. It's not a full multi-day forum, but it'll be a bit of time to explore this a bit more. I'd like to highlight that, and if you're interested, please sign up. And saying that, I'd like to say thank you. Here are some of the references that we put on the table in the slides that one of the research associates, Amber, put together in the slides that you saw. And so I'll just close today and say thank you very much. And thank you to each of the speakers, and thank you to Elder Doreen, Spence, and I know you started us in a good way. If you had any final words, I'm going to leave it to you as an elder. And to all of the people who chatted, thank you for those comments. That's part of what we have to keep exploring. I'm going to hand it over to grandmother.
Thank you again, and thanks for all the good work that you're all doing. I wondered if Dr. Kennedy had anything to add before I give parting words. Andrea, are you there?
I'm here, grandmother, and I would say the closing is yours, but thank you.
Oh, thank you. Hi. I just want to ask blessings for us as we go our separate ways, and may this virtual work reach all four corners of the universe. Bless you all, and I wish you all good health. Hi, all my relations.
Thank you. And well, everybody have a great day. Love to see you in December. And awesome.